So good morning, everyone. Today I'll be presenting a short talk on rheumatoid arthritis. So we'll cover the definition and epidemiology, the pathophysiology, history and exam, investigations and differentials, management, complications, and prognosis. So what is rheumatoid arthritis? Rheumatoid arthritis is a chronic inflammatory condition that predominantly affects the small joints of the hands and feet. It's the most common inflammatory arthritis, affecting approximately 1% of the population, and more common in females compared to males. Whilst RA is a clinical diagnosis, both laboratory and radiographic tests assist in diagnosis and also provide useful prognostic information. RA should be treated aggressively, given it can be a significant cause of work loss, reduced quality of life, need for joint replacement surgery, and mortality. So let's look at the pathophysiology. So RA is an autoimmune process that is considered to be triggered by a genetic factor and the environment. So HLA-DR1 and HLA-DR4 are known as susceptibility genes, and we have environmental factors such as cigarette smoke or a pathogen or infection. It's thought that cigarette smoke or this pathogen can modify self-antigens such as type 2 collagen and vimentin. This process of modification is known as citrullination, and it involves the conversion of the amino acid arginine to citrulline. These proteins are now citrullinated and are recognized as foreign by antigen-presenting cells due to these susceptibility genes. So there's this loss of tolerability. Antigen-presenting cells then present these citrullinated proteins to CD4 T cells. Activation of CD4 T cells leads to the following cascade of events. You have interleukin-4 production, which leads to B cell proliferation and differentiation, and this specifically produces anti-citrullinated peptide antibodies. You also have migration of CD4 T cells to the synovial joints and the secretion of cytokines like interferon gamma, interleukin-17, and this recruits macrophages. This in turn secretes more cytokines like tumor necrosis factor alpha, interleukin-1 and 6, and ultimately results in inflammation and proliferation of the synovial cells. The increase in immune and synovial cells causes the creation of what's known as a pannus, a thick swollen synovial membrane with granulation scar tissue. Over time, the pannus can cause damage to the cartilage, soft tissue, and erode bone. And these activated synovial cells also release proteases which break down cartilage, exposing the bone. Increased activation of rank ligand on T cells activates rank on osteoclasts, and this also causes bone resorption. Antibodies also enter the joint space, and in particular we have rheumatoid factor, which is an IgM antibody that binds to the Fc domain of the altered IgG, and we have anticyclic citrullinated peptide antibody, anti-CCP, and this targets the citrullinated proteins. So these antibodies bind to their targets, forming immune complexes which accumulate in the synovial joint. This leads to the activation of the complement system, which comprises of 9 small proteins, an enzymatic cascade, and ultimately joint inflammation and injury. And over time, this chronic inflammation leads to angiogenesis, so the formation of new blood vessels, and that facilitates the entry of more inflammatory cells into the joint. It's also important to note that these cytokines can travel through the bloodstream, affecting different organs and systems, and therefore you get extra-articular manifestations, which we'll look at shortly too. So history and exam. So important demographics to think about are that the patient profile tends to be patients between the age of 40 to 60. And as we said, it's 3 times more common in females than males. In terms of the presenting issue or complaint, so patients tend to complain of bilateral symmetrical pain of the small joints of the hands, so the metacarpal phalangeal and proximal interphalangeal joints, and also the feet, the metatarsal phalangeal joints, and this tends to last more than 6 weeks. They may also complain of flare-ups, so swollen, warm, red, stiff and painful joints. And as the disease progresses, you can also get large joint involvement, such as the shoulders, elbows, knees and ankle. This morning stiffness tends to last more than an hour. And with inflammatory arthritis, such as a rheumatoid arthritis, you tend to have the pain and stiffness at rest, which improves with movement. And this is in contrast to a mechanical arthritis, such as osteoarthritis, whereby you have pain with movement and it's eased with rest. You also can have, declining function, so reduced grip strength, and they may have difficulty with their job or carrying out things around the house, using their hands. And it's also important to elicit any constitutional symptoms like low-grade fever, fatigue, weight loss. And again, there are some extra-articular manifestations, which we'll cover soon. It's important as well to establish any family history of rheumatoid arthritis, as it confers a 2 to 4-fold increased risk of RA in a first-degree relative. And also, as we know in the social history, smoking plays a role in the development in terms of that citrullination of those proteins. In terms of the clinical examination, so of course we will look, feel and move the joint to assess it. I've focused, sort of honed in here in some of the features in the hands predominantly. So some of the rheumatoid stigmata you might see would be bilateral, swollen and tender metacarpal phalangeal, proximal interphalangeal and metatarsophalangeal joints. You can also have Boutonniere's deformity. So this is where you have proximal interphalangeal flexion and distal interphalangeal hyperextension. You also have the swan neck deformity, which is where you essentially have sort of the opposite. So you have proximal interphalangeal extension and distal interphalangeal hyperflexion. And you also have the Z deformity of the thumb, where you have fixed flexion of the metacarpal phalangeal joint and hyperextension of the interphalangeal joint. And you can also get ulnar deviations of the fingers due to inflammation of the metacarpal phalangeal joints, so due to that subluxation. Some of the extra-articular features would be things like rheumatoid nodules over the extensor surfaces of the tendons. And then some of these other things are less common, but you can get vasculitic skin involvement, pleuritis, interstitial lung disease, pericarditis, and inflammatory eye disease. And this is not an exhaustive list. So moving on to our investigations and differentials. So we would like to organise some non-specific laboratory tests, so things like raised inflammatory markers we anticipate to be high, so things like CRP and ESR, a full blood count, so we may see anemia of chronic disease due to that chronic inflammation which activates hepcidin, which then decreases the iron, and so you get a normocytic normochromic anemia. Thyroid function tests to rule out autoimmune thyroid disease, which can be common in patients with rheumatoid arthritis, and raised antigen nuclear antibodies may also be present in 30 to 50% of RA patients. Specifically, we'd need to look also for anti-CCP antibodies. So this is a sensitivity of 70% and a specificity of greater than 90. And rheumatoid factor has a similar sensitivity and a slightly lower specificity. It's also important to note that serological studies may be negative, and so this is known as seronegative rheumatoid arthritis, and these patients typically have a better prognosis and fewer articular manifestations than their counterparts with positive antibodies. You may also want to add LFTs and some tests to assess renal function if you're thinking ahead about the treatment as well for some baseline values. In terms of imaging, so we'd like to order x-rays as our initial test. So we baseline radiographs of the hands and feet and any other symptomatic joint. This helps with diagnosis but also determines disease severity. Early findings include soft tissue swelling and osteopenia around the joint, and then late findings include joint space narrowing and erosions of the cartilage and bone and more generalized osteopenia. Ultrasound is not routine but can complement x-ray evaluation of suspected RA, and it can be used if there's any clinical doubt around synovitis, as that's visualized quite well. And MRI of affected joint, again, if we're thinking about cervical spine involvement in the context of atlantoaxial subluxation, that can also be warranted this investigation, but I'll discuss this shortly. And any other further imaging depending on any clinical concern around those extra-articular manifestations. So moving on to some imaging. So we have bilateral and symmetrical joint involvement, and we can see in the yellow arrows here, we have proximal interphalangeal joint space narrowing. The red arrows point to metacarpal head erosions, and in the blue arrows here are pointing to metacarpal phalangeal joint space narrowing. The green circles here show osteopenia, so the darker areas, and the yellow circles are showing pancarpal and radiocarpal involvement. Purple arrows here also showing the carpal metacarpal erosion, and we have distal radio-ulnar joint loss here. And you can also notice that the distal interphalangeal joints are essentially spared, and this is in contrast to osteoarthritis where we typically get involvement here. And you can also see some soft tissue swelling around some of those joints as well. In terms of ultrasound, so we can see, this is the same image, this one's just labelled. We can see the skin, the normal bone surface. You have the pannus here due to that synovial proliferation, and then the erosion here in the joint there. And this is just a close-up of the marginal erosions. And this is the atlantoaxial subluxation. So rheumatoid arthritis can cause erosion of the odontoid peg in the C-spine, and that's due to that local synovitis and damage to the ligaments around that area. And that can cause subluxation, which is a spinal cord, which can cause spinal cord compression, and that's obviously a medical emergency. So any patient with rheumatoid arthritis who's undergoing general anesthesia and intubation needs a workup around that C-spine to ensure that there's adequate stability. So in terms of differentials, I'm not going to take us through each one of these. You can look at this in your own time, but you can see that looking at the different risk factors, the course of disease and the features, patterns and the symmetry and sort of the lab findings, you can quite nicely differentiate between different types of arthritis. Moving to management. So it's really important to urgently refer a patient with suspected rheumatoid arthritis to a rheumatologist. We really need to diagnose this early, as that way we can start intervention with disease-modifying therapy to prevent irreversible joint damage. The goal is to maximise long-term quality of life, so we want to control symptoms, normalising physical function, enabling participation in social and work-related activities, preventing joint damage, of course, and minimising cardiovascular complications, given rheumatoid patients have a high cardiovascular risk profile. Just briefly on lifestyle, so exercise is encouraged, particularly land and water-based aerobic exercises and strengthening and weight bearing. And we know that smoking cessation as well is quite important, given that it has a role in the development of rheumatoid arthritis. Pharmacologically, long-term we use conventional synthetic disease-modifying anti-rheumatic drugs, so DMARDs. These are used to induce and maintain clinical remission of RA. So methotrexate is a drug of choice for most patients, and according to ETG, the therapeutic guidelines in Australia as of July 2022, methotrexate 10 milligrams orally is given once a week. And this is in addition to some folic acid. As we know, methotrexate is loosely a folate antagonist. We want to try and minimise some of those adverse effects by giving folate as well. Disease activity is regularly monitored after starting DMARD, and therapy is adjusted to achieve clinical remission. It takes around 6 to 12 weeks to see a result, and if not achieved, then you can use some combination therapies. In terms of analgesia, so NSAID is given orally, but again, we've got to think about some of the GI upset and nephrotoxicity as well with that. So as I've stated, we have our DMARDs, methotrexate's first line. There's a few other options that can be used, and ultimately these sort of suppress that inflammation, generally speaking. If these are not effective, you can also add a BMARD. So this is a biological disease-modifying anti-rheumatic drug. And as you can see here, a lot of these target some of those inflammatory mediators that we looked at earlier in the pathophysiology. So they can also be quite effective. It's also important to monitor Hep B and C status and TB as well, because these drugs can cause a reinfection. And FBC and LFTs need to be checked before starting a DMARD as well, to ensure that there's adequate clearance of the drugs. It's also important to keep in mind that these patients are immunosuppressed, and therefore making sure they're up to date with vaccinations is also very important. In terms of short-term flare-ups, glucocorticosteroids can be used due to their rapid onset and anti-inflammatory properties, and they're quite useful in symptom control during an exacerbation or waiting for that response from the DMARD, which can take up to 12 weeks. And so methylprednisolone or pred can be used for that. And just briefly, so in terms of surgical intervention, so from my understanding, this is not as common now, given that with the advent of these DMARDs and biologics, a lot of, for the most part, the pharmacological treatment is quite effective. However, I did come across that some indications for surgery might be in patients with really extensive joint deformity, and if the patient cannot tolerate the pharmacological treatment or they don't respond to that, which would be more rare. And some of the procedures I came across would be a total joint replacement in the context of severe joint damage, which may also be associated with osteoarthritis, synovectomy, which is the surgical removal of synovial tissue. And I also saw radiation synovectomy, which is where they inject radioactive agents to the joint to ablate the inflamed synovia. So just briefly, here are some complications of rheumatoid arthritis. I might just draw your attention to the fact that there's actually increased mortality. So untreated RA leads to an average of 8 to 10 years shortening of the lifespan, which is quite significant. And there's also something called Felty syndrome, which is a complication of RA that's quite rare, defined by the presence of rheumatoid arthritis, splenomegaly, and neutropenia. And there are also some complications related to the drug treatment as well, which is why it needs to be monitored. But overall, the prognosis is quite good if it's treated early and aggressively. And so in summary, some just take-home points. Rheumatoid arthritis is an autoimmune symmetrical polyarthritis that causes chronic inflammation of the synovial linings of the joints, tendon sheaths, and bursa. Key symptoms include pain, swelling, and stiffness of the MCP, PIP, and MTP joints. Large joints can also be affected. RA is a clinical diagnosis supported with laboratory and radiographic tests, which are also useful for monitoring the disease severity, and prompt referral is essential to commence disease-modifying therapy to prevent irreversible joint damage, and methotrexate and folic acid are the first-line therapy for rheumatoid arthritis. These are my references, and thank you all for listening.